All right, welcome everybody. So excited to have you guys today for this meeting. Today we are going to be doing our IR Playbook series, chapter one or chapter three, versus which is called the Tools of the Trade. My name is Zach. I'm the Education Chair of WCVIS Chicago, and I'm currently an M4 at CMS. So whenever I like to go over a lecture or any sort of topic, it's really important to discuss why is this topic important, especially because managing tools of the trade is a really kind of tedious and somewhat boring topic. Sometimes we might ask ourselves, why do we got to learn all this? It's kind of, boring. It's not pathophysiology, it's not treatment. But really what's important about this here is that these are the defining features of what makes a good IR. So I've kind of listed some of the three features in my experience throughout med school of what I feel like makes a good IR and what makes IR unique compared to so many other specialties. What it really consists of is imaging expertise and diagnostic command. You really have to be able to be good at DR, even though the IR mindset is slowly shifting towards surgery as it should. What really sets us apart from, say, vascular surgery, interventional GI, interventional cardiology, is our command of imaging and all throughout the body systems. The other part of that is kind of what we talked about a little bit earlier was the surgical mindset. It's having that full longitudinal clinical ownership of your patients from the preoperative stage, the operative stage, postoperative, and then longitudinally following them up. And finally, now we have the tools of the trade, which is what we're going to be talking about today. The thing about it is as med students, as early trainees, we don't really appreciate this as much, just because we rely on our attendings and our residents to really take over this aspect of it, right? But when you really master the tools of trade, you get to appreciate how IR does the things it does and how we can kind of improve from here on out. So, kind of like a primer before we really jump into the tools of trade, we really have to discuss what are the important measurements in IR. So, the first big primary measurement is actually called French, and it's describing the diameter of catheters and sheets. What you have to understand for the conversion is that one French is equal to about a third of a millimeter. So, therefore, continuing that conversion, three French is about 1 millimeter, and six French is 2 millimeters. To sum it up, the higher the French number, the larger the diameter of said catheter or sheath. The other important measurement we got to talk about is inches here. The diameter of wires is usually measured in inches. It's the most commonly used wire sizes are going to be 0.014, 0.018, and 0.035, with all of those ascending upwards. The wire diameter should be less than the inner diameter, however, of any catheter that you use. So the way that you kind of do this conversion, there's a couple math problems that you can do, but the easiest thing I like to remember whenever I need a quick reference is that a 0.018 wire, which is your smallest, most commonly used wire, is going to fit within a 22 gauge needle or a 3 French catheter. So if you're going to use a bigger wire, you're going to need to use a bigger catheter going forward. So when it comes to the third important measurement, we have centimeters. The length of almost all the devices in IR, whether that's catheters, wires, sheaths, are all measured in centimeters. Generally speaking, a wire should be about 2 times the length of any sort of catheter. And the reason why we do this is because when you're threading the catheter down the wire and into the vessels, that can create a lot of movement within the body. And so really doing this extra wire length and accounting for it is going to prevent movement during the exchanges. And so it helps you keep that vascular access. The most common wire lengths that we really use in IR are going to be 80, 145, 180, and 260 centimeters. And then the final really big important measurement in IR is something that we've pretty much all heard of at this point. It's the gauge. And that's what defines the diameter of the needle. And for this one, it's the one that's kind of less intuitive. It's a little bit opposite here. The smaller the gauge, the larger the diameter of the needle. So an 18 gauge needle, even though 18 is lower than 21, is by diameter bigger than the 21 gauge needle. And so the most commonly used needle sizes, really in all of healthcare, but especially in IR, is going to be an 18 gauge to 22 gauge needle. And so one of the most important other aspects of IR as a primer is something that we like to call the Seldinger technique. And it was a vascular access technique that was invented in around 1953 by Sven Seldinger. And it allows for the safe, reliable percutaneous access of any hollow structure within the body. So that could be arteries, veins, lymphatics, anything else. And it's really used for diagnostics and therapeutics. So going through the steps of Seldingers, and I'll play this video in the background. Really, what you're going to be doing is first identifying the vessel of interest under ultrasound guidance and aiming for an entry angle of about 45 degrees to the skin. And after doing that, you're anesthetizing the skin with about 1% lidocaine. And then another technique that they like to do is incising the skin and blunt dissecting, just to clear out any sort of tissue that could be interfering with the needle's entry. Once you've entered the vessel with a micropuncture needle, you're going to center the needle tip in the vessel lumen, advancing a microwire into the vessel lumen through the needle hub, and there should be no resistance whatsoever. If you do encounter that resistance, that's when you know you got to pull the wire out because you're most likely nicking into the artery or the veins walls. And finally, once you get the microwire into the vessel lumen, you're pin pulling the needle off of the microwire. So those are short movements where you're keeping the microwire in place but pulling the needle out. And you're going to be exchanging it for what's called a 5 French transitional dilator. And so what that dilator is that it helps to kind of spread apart the tissues a little bit more and gently, less traumatically open up the arteriotomy or venotomy sites to be able to allow for a smooth entry of your wires. Once you have that 5 French dilator in, you're going to be removing the inner dilator and microwire that's there and advancing your larger wires through. And so with that, you've kind of safely and less traumatically gotten into that vascular access and gotten your purchase at that point. So in order to do this, there's a standard way that IR procedures almost always start. Whether you're doing vascular, whether you're doing lymphatic, it's always going to start with this vascular access technique. And so you have to really understand, being a med student or an early trainee, to be helpful on the team, you have to know what's in your kit. And so the standard micropuncture kit for any vascular access really consists of a 21 gauge needle, a 0.018-inch guide wire, that transitional dilator with a 3 French inner and a 5 French outer. And overall, this set allows for the introduction of a 0.035-inch wire to the vessel of interest. So now really diving into the tools of the trade, we're first going to be talking about needles. Overall, kind of like we touched on a little bit before, needles come in all different shapes, sizes, lengths, gauges, but a good classification scheme to follow is dividing needles into 4 categories: the standard hollow, the coaxial, the sheath, and the specialized needle. The standard hollow needle is really going to consist of your classic single-walled hollow cannulas, and it's going to have a bevel tip. Think of any time you get an IV done, when they're drawing up medication, getting injections, anesthesia, and this is like we mentioned before for vascular access. The next needle type that's really important for IR is coaxial needles. And so the two big examples that I have listed up here are called the Chiba needle and the trocar needle. And what these are is that they consist of an outer cannula and an inner stylet. So I think you guys can see my mouse here. This little grayer portion of the needle is that outer cannula, and this whiter portion is the inner stylet. And same for the trocar. The Chiba and the trocar, the reason why I brought those up is because those are the two most commonly used when it comes to coaxial needles. And the Chiba, also known as the INRAD, which is you'll commonly hear whenever you're doing away rotations, it's going to really consist of a beveled cannula and a stylet. So both of them are really similar in shape. And then for the trocar needle, you're going to have that blunt outer cannula, so this cannula at the bottom, and then a diamond style tip right here. So it's really going to be used great for puncturing and accessing deep structures. What these coaxial needles are used for is mainly for biopsies as well as non-vascular access. And then a third category that's important for IR would be the sheath needles. And the reason why these are different than coaxial is that they consist of a plastic outer catheter and a metal needle stylet. So it's really similar to the trocar needle in that the outer plastic is blunted. There's no tip to it. But the difference is the materials. One is metal versus one is plastic. And so the reason why we use the sheath needle specifically with a plastic cover is that it's commonly used to access and drain a lot of fluid collections. You can imagine if you had a stiff metal outer cannula in a fluid collection, let's say it's moving really fast, that can really shift the tip of the cannula out of the fluid collection, and that would impair your drainage. Whereas a plastic catheter, it's a little bit more flexible and it's able to move when that fluid collection is moving. Another commonly used needle, which you'll hear a lot, especially for paracentesis, is called a UA needle, and it's a very similar thing. It's just a sheath needle as well. And then finally, for that last category, we have specialized needles, which can range in different procedures that you're doing. But the most common ones that we see, at least day to day in IR, one of them is called the Huber needle, which is this 90-degree tip that you're going to insert directly into ports. And some of them are really special because they also don't core the valve that's on the port. And so it self seals itself. And then another one is called the Varese needle, which is a really cool one. It's a spring-loaded blunt tip that when you're, for example, going through the peritoneal cavity, because there's bowel there and you don't want to perforate it with a sharp needle, Whenever that needle detects that there's resistance or bowel coming near it, it will actually spring load and shoot out the blunt tip, so that it just kind of glazes right off the bowel. Okay. And so now kind of going through needles, we got to go to the next category, which is wires. So before we start talking about any sort of wires or their characteristics, we really have to understand what they are. So wires are really long, tightly coiled springs that are used to advance other devices, such as catheters, into those arteries, veins, and other hollow structures. And there's three main parts to any wire's anatomy. You have the coil spring, which is these circles here represented on this diagram, and they wrap around the entire length of the wire. Then you also have the mandrel, which is kind of this pointed core piece right here at the bottom. And then you have what's called the safety wire or the wire guide. And if you see this black line traversing the entire length of the wire, what that does is that it connects the coil spring from one end all the way to the other, and it keeps the wire kind of tightly sealed together. And so with IR, there's so many different wires to choose from, and sometimes it's really difficult to understand why we're using a certain wire or what the purpose is of it. And that's just simply because there's so many characteristics we can alter inherently to every wire. Whether that's the length or the diameter, which we talked about is measured in inches, and we had the common sizes and lengths. That could be the tip shape. For example, some wires have a curved J tip that blunts the wire tip so that when you're entering into the vessel, it causes less trauma. Or you could have straight and angled tips, which are mainly used again for access, selection, exchange, crossing over vascular occlusions. Then you could also have the stiffness of the wire, which that one is really dependent on the mandrel's core, that angled piece that we talked about on the anatomy diagram. And so what that consists of is the diameter and the composition of the mandrel that determines the stiffness. Stiff wires, as a basic rule, are going to act like railroad tracks. They're going to provide really good support for exchanging devices without having as much movement or bucking under the weight of those exchanges. Then you can also have the flexibility, which is the mandrel's taper. So if you guys see this diagram here, the mandrel kind of points down, right, from this standard diameter it has. And that taper is what determines the wire's flexibility as it's going through the vessels. In general, a good rule of thumb is that a short taper is going to indicate greater maneuverability, meaning you can change the tip since there's no core that's dictating that tip. But it does mean there's less pushability, meaning if you need to get through a really stenotic vessel or if there's a high occlusion, it's going to be really hard with a short tapered wire. Versus a long taper, lower maneuverability, it's harder to wind through vessels, but you do have greater pushability, meaning that if you add a little bit force, it'll get through some more occlusions greater. Then you have the coating of the wire. Wires can be generally coated with tons of different materials, chemicals, properties, and they all give different properties to the wire. Some of the most common coatings, which it's lower yield to know, but still important, is the Teflon, Tefla, heparin, and hydrophilic polymers. As you can imagine, heparin would be great because it prevents some of the thrombosis that occurs in vessels. And then you have torqueability of the wire, which is the wire's tip and its ability to turn when you push the back. So when you have the wire into the body, you can't really see the tip. It's hard to control it at that point. And what you do is you twist it back and forth along with pushing it back and forth. And so the ideal torque ratio is about a 1-to-1, meaning if I turn the wire from the back 180, the wire should also turn 180 in the front. However, that's not always the case just because we meet a lot of resistance when we go through the vessels. Some wires don't have great torqueability as a property. But in general, better the torque, the better the navigation. And then finally, another last characteristic that's inherent to wires is their opacity. You could add materials to the wire's coat to enhance visualization under fluoroscopy, such as tungsten or platinum. And so, really, when you think about it, there's so many alterable properties of wires that there's so many classification schemes that exist that really do effectively categorize the market products. However, how can we make it really useful for med students? Just to highlight here, I won't stay on this slide too much, but there are some of the categories you can classify it as hydrophilic wires, wires that kind of really slippery and glide through the vessels as pretty well, or non-hydrophilic, which they don't have that same property. Then again, we have the diameter of the wire, which the standards we talked about are the 18 and the 35. And then finally, if you look at this box here, you can also look at the stiffness of the wire. So even though two or three wires might be hydrophilic and 035, they might vary in their stiffness. For example, the Roadrunner is generally speaking more stiff than the glide wire. So considering all these properties, how can we make the wire classification schemes really applicable to us? I think that at the student early trainee level, it's critical to understand that each wire has a purpose. Certain tools are better suited for certain circumstances, And misusing any one type of wire can have really catastrophic consequences, whether that's perforating a vessel, dissecting it, causing thrombosis, and even if you're using the wrong wire, it could actually break off and embolize and cause a ton of problems. So the real big classification that I like to use, especially for early trainees, is the use purpose classification, which you kind of divide up the wires by their properties and what could we use them for? What's the purpose that we use them for in these procedures? So in general, metal working wires, which are going to consist of your Benson wire, your Rosen wire, your Amplatz wire, and your Lunderquist on this side, those are really good for access, exchange, and being those support rails, those railroad tracks I was talking about. On the other hand, your glide wires or your guide wires, which are hydrophilic, they're really good for navigating those tortuous vessels and difficult anatomy. That's inherent to their properties of being able to glide along vessels really well. And then also maybe some of them have that short taper as well, which, like we said, greater maneuverability, decreased pushability. And then another category you have is your micro wires, which we don't see as commonly. It's often used really for neural IR and some sensitive cardiac procedures, or if you really need to get pretty distal in the vasculature. And then this diagram here comes directly from the IR playbook. It's a really good breakdown of kind of what are the exact uses for some of these common wires. The Benson and the J are strong axis wires. Those are usually really common in your axis kits, or you can use another one called a cope mandrel. The Rosen wire is an exchange wire often used in angioplasty. Your glide wire, like we said, going through those tortuous and narrowed anatomies. The Amplatz is a really stiff wire, and that provides really good support when you're not only doing exchanges, but going through really dense tissue. And then your Lunderquist, it's a pretty rarely used wire, but it's kind of like the big guns when it comes to stiff wires. Some people like to compare it to what's a coat hanger feels like when you unravel it. That's how stiff it is. And it's really big for supporting large interventional devices like endografts when you're doing aortic work. And then you have a bunch of specialty wires. Some of them are all purpose, but those have their own niches. So finally, now that we've talked about wires, we can move on to catheters now. And just like wires, there's probably even more classifications of catheters and many more being made. They come in a ton of different shapes, materials, constructions, and each of them are designed for a specific purpose. But another good classification scheme that we can divide tapered caths into is the flush, the selective, the multi-purpose, and the cerebral. There are some other categories that we will try and discuss a little bit later too. So going through the first category here, we have the flush catheters, which these are non-selective catheters, meaning you're not trying to specifically select for a vessel, but they do have multiple side holes. And what this is really used for is the rapid injection of liquid materials, be that contrast, saline, medications. And so it's really good. You can imagine if you're going up to the aorta, which is a huge vessel, you're not necessarily selecting for anything. But let's say you want to go into the aorta and image that, do an angiography, or the IVC, or the common femorals, whatever it might be. Those are large arteries that if you just do a little push, no matter how hard you push, it's going to be really hard to image them just because the contrast is going to wash out really fast. However, if you have a flush, you can get a huge volume in a quick amount of time and be able to image that properly. And then you also have selective catheters, which these are the ones you kind of classically think about. These are curved, pre-shaped catheters, usually without any sort of side holes. And these are meant to catheterize specific branches of the aorta or any sort of vascular trunks that you're trying to access. The main categories that we will talk about in a couple slides is the visceral and the reverse curve. At least those are the most important to know right from the get-go. Then you have your multi-purpose, which is a version of those selected catheters, but unlike the selective ones, they don't really have a curve to their tip. It's more of just an angulation. And these are also commonly used to select for vessels, but more so to navigate through really stenotic or tortuous vessels. And then you have the cerebral ones, which again, mainly used for neurointerventional cases. It's another version of the selective catheter, so you won't see it as commonly in regular body IR or in the day-to-day use. It's really most useful for vessels that are arising out of thoracic aorta and going up to the head. And you have to understand that as you go up higher and higher, the complexity, the tortuosity of these vessels increases. So that's why you have these really specialized cerebral catheters. So going through our first topic, which is the flush catheters, like we mentioned, using these flush catheters is really great because it increases your injection rates by about 10 to 20%. The common thing that you might think of is, hey, when I'm sending a guide wire through a flush catheter, wouldn't the guide wire kind of get stuck through one of these holes? How can I kind of ensure that it goes through? Well, actually, the designers were pretty smart about this. They made the side holes intentionally a lot smaller than the end hole, which prevents the guide wire from escaping and exiting out of them. So looking towards this diagram here, Looking just left to right, we have first the straight flush catheter. This is the pigtail catheter, and this is another one called the omni flush, and just another pigtail here as well. So they each have different uses, even though they're all flush catheters. The pigtails mainly allow for 360-degree injection delivery, so it's really good when you're in those large vessels. You want to send a huge volume out, and you want to just go everywhere, up and down. The OmniFlush, on the other hand, has a really good, it's almost like a shepherd's hook shape. And it's really good when you have a large vessel bifurcation. Think of like the iliac bifurcation, the aortic bifurcation. And so let's say you're ascending up the left side. If you want to get to the contralateral side without putting your catheter all the way at the in, you can kind of hook the shepherd's hook on the iliac bifurcation and image both sides. And that's because of the side holes and the end hole as well. And then this diagram up here is straight from IR Playbook. It's just more so, it's not something you have to memorize, but it's more so these are recommendations for injection rates when you're in certain vessels, not only that the catheter can accommodate, but also to protect the vessel from any injury. And then continuing on with catheters, we have our selective catheters, which is by far the most important thing you should know. So going over the anatomy first of a selective catheter, each catheter has a primary curve, which I've indicated right here with the red arrow, and that's usually near the tip. And so like you can see in both of these diagrams, this primary curve at the tip here is what usually engages the vessel. That's where you're really going to use to catheterize the vessel. And then at the blue arrow here, you have a secondary curve. And the purpose of this secondary curve is really to stabilize the device against the vessel wall. So looking again with this diagram that here, the primary curve engages the vessel, while that secondary curve kind of keeps the rest of the catheter straight to butt up against the vascular wall and kind of give you that good support. Via imaging, the branch angle, pathology, and tortuosity ultimately dictate what catheter is most appropriate to use in any given scenario. However, you'll also see sometimes providers really have preferences for which catheters work for them, what they might have the most exposure to, and so they might not necessarily follow the textbook guidelines for it. And so going through some of our specific catheters here, we're first going to talk about that visceral category that I talked about. And so these are your angled or curved catheters with shapes specifically designed for specific vessels. And usually these are the mesenteric vessels. So you can think of the celiac trunk, the SMA, as well as the IMA, and any of their branches. So pictured left to right, we have the Roche catheters, the IMA, celiac 2, and celiac 1. And then you also have more commonly used the Cobra ones, which are the 1, 2, and 3. And all the numbers really indicate, and all that you have to really remember is that the higher the number, the greater that secondary curve is going to be. And then other common names that we see in visceral catheters, these selective ones, are the Compi, the Vert, the GlideCath, and the MPA. And then going on to our next category of selective catheters, we have the reverse curve, which are a really unique subset. Pictured left to right here, we have the SOS, the Michelson, another Roche, and then the Simmons. And all of these also have 1, 2, 3 gradings as well. And so what the reverse curve catheters are is that they are a subtype, again, of those selective catheters. But this time, if you notice the difference, this one has a primary curve as well as a secondary curve. Primary curve, secondary curve, primary, secondary, primary, secondary. However, they go in opposite directions. So you have one that's up going and another one that's down going, up going, down going, and so on. And so what the usefulness of this for is going back to this diagram on this left side here, is you can access some vessels that are caudally angulated towards the feet, whereas other selectives might not engage them. So you can kind of see that this reverse curve catheter right here is really, it's optimally suited to catheterize this vessel just because it's caudally angulated going down. And then going on to that microcatheter discussion that I talked about, they're really specialized and really small 1.5 French to 3 French catheters that are mainly used to reach really distal vessels and achieve super selectivity. Unlike their larger counterparts, the microcatheters can have straight, curved, or angular tips, and some of them even allow operators to change the tips curve manually while you're in the vessel. Often these are subclassified between neurointerventional and peripheral microsystems, and there's tons of ways you can integrate them with much larger systems as well. And so if you look here at the diagram, we can see that we have a catheter. This is just a microcatheter with a radiopaque marking, and then a microwire going through it. And then here, integrating with the larger system, you have, for example, another selective catheter, it appears to be, and then a microcatheter underneath it. And where the yellow arrow is that radiopaque marker. So you can see how much smaller a lot of these catheterization systems get and how we can be super selective when needed. And going on to the next tool that we have here, it's sheets. And so sheets you can kind of think of, I guess let's start from backtracking a little bit here. Wires, we know, go through catheters. What do catheters go through? That's what these sheaths are for. And so sheaths are really mainly supposed to be conduits that allow for catheter exchanges. They also have some other functions that are good benefits. They provide improved torque for catheters, stability for interventional systems. Whenever you have a ton of catheters, ton of wires in there, it can get really jostled around whenever you're making the slightest movement. So that stability from the sheath really helps. And it also decreases access point bleeding just by filling out that arteriotomy site much more. On top of that, you have valves that cover the sheaths to prevent any sort of air or even blood from possibly leaking out. And then you have secondary valves on the side right here, where you can flush and clear out any blood, clots, hopefully no clots, and hopefully no thrombus that forms. Now, these sheets, they can range from 4 French to 28 French, which are quite large. The sizing, however, it's really important to know this. The sizing refers to the inner diameter of the sheath. So going back to catheters here, sizing, when you're talking about French, goes to outer diameter. When it comes to sheaths, French refers to the inner diameter. And so whenever you want to figure out, hey, how big of a sheath do I need to fit this catheter? You always need to remember catheter size has to be less than the inner diameter of the sheath. And so whenever you're also calculating the outer diameter of the sheath, you have to automatically add 2 French to obtain the outer diameter. So let's say I have a 5 French sheath that I'm putting into an arteriotomy site. If your attending might ask you, how big is that arteriotomy site going to be? It's not going to be 5 French. It's going to be 7 French because you have to account for that outer diameter of the sheath. And so once placed, sheaths do require continuous flushing, which is why we have that valve, that stopcock there on the side. And the reason for this is because, as you can imagine, with this large diameter here with catheters, wires running through it, you have a lot of blood sitting in there. And so that can lead to thrombus formation, including the sheath. And let's say if you move the wire a little bit, dislodge that thrombus, it can start to cause thromboembolism. And so what you really have to do is do this continuous flushing through the sheath. Once the inner dilator is removed from the sheath valve, catheters, wires, and other accessories can then be placed through the sheath and used as that conduit. And so another good important tool that we have here that kind of gets less appreciation, but it's also important, is the vessel dilators. And so what these vessel dilators are is it's literally just catheters, these kind of tapered tubes that come out here. And they're about 20 centimeters long. They're stiff. They're usually made with nylon or Teflon. And what these specialized devices allow for is really the separation and expansion of tissue or vascular access sites prior to introducing any sort of catheters and sheets. We talked about how a 21 gauge needle is the standard micropuncture, and a 0.018-inch wire is usually what's used to get that access. But let's say you need to use an Amplatz, which is that stiff wire, right? And that's a 0.035-inch wire. So if you try and push that in without dilating first, that's going to be really traumatic to the vessel. It can cause vasospasm, rupture, perforation, all those complications that we don't want. So this is why we use dilators, and we do it in a serial dilation pattern. Typically, we accomplish this by doing two French increments to dilate the site to the sheath size, which is again, you want to get to that outer diameter. And so now we've kind of gone through a lot of the big important tools that we have in IR, the standard ones, the wires, catheters, needles, sheaths. Let's talk about some more fun things like the accessories. So first we have the flow control devices and torques, which I promise you get sexier later on. The commonly used flow control devices that we really use a lot in IR are the flow switch and the TUI adapters. And so if you look here, the flow switch is it literally looks like a small little tube and it has an on and off switch. And it's a one-way valve with a switch that, like you can imagine, turns flow on and off. The TUIs, which are a little bit more complex looking on the right, they have a hemostatic valve that you, instead of switching on and off, you tighten and you loosen. Often this is used to prevent backbleed around microcatheters, and they also have flushing capabilities so you can prevent any sort of clot and thrombus from forming. On the other hand, here you have the torque devices, which are used in conjunction mainly with hydrophilic guide wires and micro guide wires. And like we said, the main reason for this is hydrophilic ones, they are really slippery when wet, and then on the other hand, they get really sticky, and it's hard to maneuver them in either scenario. So what you really need all the time is a torque device. And what you do is you thread it by the back of the wire, and once it's threaded through in the appropriate place, you can kind of screw it down. And this allows operators to improve their torque, which like we said, when you turn the back end of the wire, it helps to maneuver the front, and it allows operators to rotate the wire in that one-to-one direction that's really preferred. 180 turn on from the back leads to a 180 turn in the front. Most torque devices in general can be attached to a 0.14 inch or 0.038 guide wire. And the most commonly used torque device is this little one with the little green knob here. I've never seen this one at the top. So now we get to the much more fun stuff, which is the accessories here. And here I'd like to first talk about the embolic agents. So the first most commonly used, or one of the most commonly used embolic agents is foam. And so the most common subtype of that foam is gel foam, which is a temporary absorbable sponge derived from gelatin that achieves hemostasis for days to weeks on end. And you can really make this into a couple different combinations depending on the need. Sometimes you can make it into these little pledgelets, which are kind of like these little broken up fractions of a foam that can be used for various different scenarios. Then you also have the torpedoes, which you kind of stick into the needle and inject out. And so that's one way to do it. And then the last one, which is much more commonly used and I think is much cooler, is the slurry. What you do is you pack gel foam into syringe and mix it in with contrast and saline back and forth. And it kind of creates this really thick, viscous foam mixture that you then inject as an embolic agent. A less commonly used one is lapidiol, which is a temporary oil-based viscous embolic. And really what it is it kind of it's almost as thick as blood. It clogs up that vessel, but with a lot of oil instead. Then you have another fun one is coils. So what this is, it's a permanent mechanical embolic, and it really requires the patient to have functional platelets because you can put the coils in. However, the real magic happens when the body's platelets bind to those coils and create a thrombus. Another aspect about coils that's important to understand is that you often need to oversize them for vessels. If I fit coils into a certain vessel and it's just barely meeting that diameter, you can imagine that it's pretty easy as blood is flowing through as time passes for those coils to migrate, shift outward, and then they lose their effect. So you need to oversize for the vessel so that it kind of really abuts those vessel walls and stays in place. Some differences between coils are the pushable versus detachable version. The pushable ones you manually push through the catheter, and the detachable ones, there's a whole delivery system where once you push it through, the system detaches from the coils. The differences that you really have to know between them is that the pushable ones, once you push it through the catheter, there's no way to retrieve it afterwards. You can't retract it back through the catheter, you can't pull them out. So you have to be really certain about your placement. On the other hand, the detachable ones, they're because it's a whole delivery system that's connected to each other, you can easily retract it before you deploy. Let's say if your placement is off, if you're not happy with the coil placement, you can kind of move it and take a restart again. The other important feature about coils is that some of them actually contain these thrombogenic fibers to help aid in occlusion. So it helps the platelets. Maybe people with coagulopathy can still be partakers in coil. Then you have another class of embolics, which is the particulates. And some of the types of particulates are PVA, which is polyvinyl, I think acetate. And what it is, it's a permanent, irregularly shaped plastic particle that produces some localized inflammation and thrombosis. So this diagram is more so depicting microspheres, but you can kind of imagine if I took plastic particles and sent it down distally into this vasculature, if I start to have local inflammation, some of you guys remember from your basic foundational classes is that when you have localized inflammation in that tight space in that vessel, it causes and induces thrombus formation. And so that's where these shaved plastic particles come into play. And then this diagram, which again more so depicts these microspheres, these are pre-made syringes of embolic beads. And so these are really tiny. They range in ton different sizes from micrometers. And you can also pair them with chemotherapeutics to form chemoembolizations as well. And then finally, another big class of embolics are the liquid agents. The most commonly used ones, and there's tons of them, but the ones I see the most I wanted to talk about were the glue and the onyx/lava. And a lot of these are really just polymers. And so the glue, it rapidly polymerizes when it's contacting ionic substances, specifically plasma. And so just recently had a case about this actually. When you're using glue, you have to keep it in a completely non-ionic environment because if you do, it can start to get stuck. It can start to polymerize and get stuck in the catheter, get stuck in vessels that you do not want it to get stuck in. So the environment has to be completely ionic. You're flushing all of your catheters, all of your wires with non-ionic D5 W, which is just another solution that kind of sterilizes the whole area and makes sure there's no polymerization that happens too early. Then you have another system which is called onyx, and a similar one is called lava, which is an EVA polymer that's dissolved in a chemical called DMSO. When you have contact with water for this substance, it induces polymerization again. And so you can kind of see from this diagram here, it's really important whenever you're using liquids because they're so volatile, they can polymerize really rapidly and can go a ton of unintended places. That let's say you have an aneurysm right here, you're going to occlude the aneurysm neck with a balloon and send your catheter up into the aneurysm. And so then, sorry. So then once you've occluded the aneurysm neck and sent your catheter up, you're going to start to fill it with that polymer. And that's going to, once it polymerizes, you're good to move the balloon. But until that moment, if it doesn't polymerize and you move it too early, that's when you can start to send embolic glue everywhere. And so another fun accessory that we have for the tools of the trade are these stents. And what these are from a basic standpoint are metal scaffolds that when they're deployed, apply radial stress to narrowed areas of vascular walls to maintain their vessel patency. Since their creation, there have been many different types of stents made, each with their pros and cons. So kind of going through some of those stent characteristics, you have balloon expanding stents, which can be pre-mounted onto delivery systems or can be hand-mounted on a delivery system. Overall, the benefit of balloon expanding stents is that there's more precise placement than self-expanding stents. Some of the common names you'll encounter when it comes to stent types are VBX, Palmaz, and OmniLink for the balloon expanding category. Then you have the self-expandable, which these are systems where you have a catheter over or some kind of sheath over the stent itself. And what you do is when you get to the right placement site, you're going to retract the delivery catheter, which that sleeve retraction exposes the stent, allowing for that expansion to happen. Overall, the benefit of the self-expanding stents is even though that they have less precise placement, they do have better radial strength and can hold up against the pressure of the wall. Some of the more common names that you'll encounter are Viaban, Viafort, and the wall stent. Then another category, which we won't talk about much just because it's hyper specialized, are the specialty stents, which mainly you're going to use for non-vascular procedures. Things like the Viator for tips, the Wallflex, and the Viabil for biliary interventions. Then you have some things that you've heard probably more commonly are the bare metal and the drug-eluting stents. The bare metal stents are stainless steel stents without any sort of special coatings. These are literally just metal scaffoldings. And what it does is that once you've placed the stent, the artery is going to start healing around that stent. But tissue growth, which secures that stent in place, can sometimes overgrow. And what that does is when you start to overgrow through that scaffolding wall, that can also lead to blockage and reocclusion of those arteries. So that's some of the cons of those bare metal stents. When it comes to the drug-eluting ones, those are coated in some extended release drug formulations, which really prevent that tissue overgrowth and gives you a patency advantage over time. So it keeps that vessel from over or that tissue from overgrowing and reoccluding that vessel. Then you also have these covered stents, which that's when you get into the topic of endografts. What these are is these are metal mesh stents that are grafted with fabrics or synthetic coverings. And this also allows for vessel patency, but seals off problem areas. So if we kind of go back to the aneurysm picture that we had previously, um, let's see here. If you had a covered stent over here, what this does is this kind of seals off the neck from being exposed to that blood flow. And so it prevents the aneurysm from continue to grow further. And that's really one of the benefits of these covered stents. Another thing is if you have a vessel perforation, that can also seal off that area while still allowing for the vessel to have that open patent flow. And then finally, you have biodegradable stents, which are a fairly new invention. These are temporary scaffolds, often made of resorbable metal like magnesium, or polymers, which support blocked vessels. And so these are promising. However, there's not enough data to support their consistent use in the healthcare setting at this time. And so now going on to another really fun tool, which is the balloons. And so you have three main categories I would like to talk about. But before we get to that, the goal of angioplasty, it's really important to understand, is to increase the intraluminal vessel diameter without removing any sort of plaque material. These balloons can be classified into many different categories, mainly compliant, non-compliant, and semi-compliant. The compliant balloons mold to the vessel wall and are pretty atraumatic, whereas the non-compliant balloons are really rigid and they're designed to blast that atherosclerotic plaque against the wall. And so when you have these three categories here, I really divided it out into embolectomy, angioplasty, and drug-coated balloons. So the embolectomy catheters, which are mainly going to be represented by the Fogarty catheters, are over-the-wire dual lumen systems. And what that really means is that one side has a area for balloon inflation and another has a slot for a guide wire. And what you do with these is that you traverse the vessels, you inflate them, and then you gently pull to remove plaque from the walls. So you can see from this diagram, we have already, with the Fogarty catheter, traversed the vessel lumen past this area of stenosis and plaque. And then once we've inflated it, which in a fairly atraumatic process here, you can see that it's kind of really molding to the vessel walls. You're going to pull that balloon back and it's going to gently pull off that plaque out of the vessel. Then you have your third type, which is those angioplasty balloons, which are mainly going to be, again, those non-compliant balloons. Their real goal is to blast that plaque against the wall and clear out space. And so what these do is that these inflate to a predetermined diameter. You'll learn eventually about these pressures called nominal pressures and bursting pressures. Nominal is the pressure you generally need to kind of get to a certain vessel diameter, versus bursting is, of course, when the balloon will burst, and you don't want that to happen. But what it does is again blast that plaque material into walls, and it clears vessel blockages. It's often paired with stenting to maintain that vessel patency for long term. And then finally, a newer type of balloon is the drug-coated balloons. What these are is that they were developed to increase long-term angioplasty patency rates. So following inflation, you have a drug coating, often paclitaxel, which is an antiplatelet drug. It's released into that vessel wall following the balloon inflation. And this prevents that tissue overgrowth, the hyperplasia, and then therefore restenosis of the vessel. And then finally, just real briefly wrapping up this presentation here, there's not much information that I wanted to provide too much on it yet, because it truly deserves a lecture of its own, but it's back table skills. You can learn all the tools of the trade you want. However, your skills at the back table is where you're really going to start off as a meta student, as an early resident, and that's where you're going to shine the most to really get to that front of the table eventually. And so I would say whenever you guys start rotations, whenever you guys start to interact with your nurses and tech, make really good friends with them because they will teach you the back table. Everything from how to handle a wire, how to flush, how to prepare all your catheters, your sheets, and then what are the tools that you need for each and every single procedure. And when you really understand that, use these tools of the trade materials that you've learned to really understand what's on the back table. What can I do to bring up to the front? And slowly over time, you'll impress your attending enough that he'll let you be the secondary operator. And so here are my references. Thank you guys for this time, and especially want to thank the WCVIS Chicago team for all your support in making this project come to life. I'm really excited to see where this goes and hoping that all of you guys kind of use this as a model to start your own lectures.
Zach, are you open to taking questions?
Yeah, more than happy to. And let me pull up the slides again too, if anyone wants to see anything else.
I guess I'll start with a really basic question that might seem silly, but so going back to the first slide where you're talking about measurements of IR, so there's French, inches, gauge, they're all measuring the diameter of something. But if they're all measuring the diameter, why can't we just use like French for both the catheters, wires, and needle? Why do they have to be all different?
Because in medicine we like to make things really hard. That's the answer. No, I mean, quite honestly, what the biggest thing is, it's a lot of things in medicine, as you've probably learned by now. It's a lot of it's historical. It's basically the people who invented these things, who discovered a lot of these measurements. That's who we're named it after. Literally, the French was called because the guy was French, and so that's why we have that measurement. And so that's kind of the reason why we have all these different measurements. And because of how far we've gotten in terms of making all these tools, how far everybody's gotten used to using all these different conversions, that's generally speaking why they don't refuse to change it and make it a standardized system. The other helpful thing too is because we have these different measurements, it helps us to be a little bit more cognitively aware as well. When you're using certain wires, certain sizes, then you're like, okay, I know that will accommodate this will accommodate this, so I could be really much more cognitively aware. So I guess you can look at that as like a benefit of it.
Yeah,
Yeah.
makes sense. Thanks.
Just to follow up on that, in the operating room, are they referring, like, will they just give you the measurement so you know, since each measurement's different, like if they just give you, let's say, like 0.018 inch, you know they're talking about a wire, right? Is there anything else that uses, like, shares the same measurements?
So that's
Or,
actually, oh, go ahead, Asher. Sorry.
no, that's about it. Yeah.
Yeah. I was just saying that's actually one of the other highlights of why there's the need for different measurements. It's because when I say 0.018 wire, or even if I don't say wire, if I say 0.018, everybody in the room knows that I'm talking about a certain wire size. I'm not talking about a needle, I'm not talking about a catheter, I'm not talking about a sheath, right? They know it's a wire size that I'm talking about. So that's another benefit of why we have those different measurements. And yes, to answer your question, when you do start out especially, they're gonna if you ask for a certain wire catheter sheath, and they'll know like, hey, or if they're handing you it saying, Asher, here, take this, this is a 5 French dilator, right? It's because they're kind of accounting for liability to make sure that, hey, if you hand the attending something, that you know what it is that was handed, they know what it is was handed, so they will often call out measurements. However, I want you guys to imagine the scenario where you're a resident on call, you're the only one in the hospital, night shift, suddenly a PE thrombectomy comes in. You don't really have time to be shouting out, hey, I need a 0.018 glide wire advantage this long, right? You don't have time to necessarily call all those tools out. And so what you got to do is you start to really learn the shorthand of what these wires and instruments are called, because in those urgent scenarios, that's what everybody's going to refer to. And so let's say that you're the one who's assisting the case. If your attending calls out a short name and you don't know it, that's going to be causing a hindrance to the case, right? On the other hand, if you want something, if you're from a nurse, a tech, whatever it might be, if you start calling out long names, it's really going to also delay the case. So that's why it's really, really important to first understand the complete measurements and the complete names of everything. And as you get more rotation experience and clinical time, you'll start to get the shorthands.
I have a question about tool selection. So, in the different programs that you did a ways at, did you find that tools like something specific like embolics, did you think that they were more user dependent or more department dependent, if that makes sense? Like, for example, let's say there's like a gold standard size for like hemorrhoidal artery embolizations for beads. Would you say that different attendings use different sizes depending on um, their preferences, or do you think that the department had like a standard size only from one vendor?
Yeah, it's honestly a little bit of both, just because for just like you said, the department when it comes to department sizes, bigger hospitals, tons of resources, right? They're going to be paired up with Boston Scientific, with Temura, with all these big manufacturers of all these different devices, right? So they're going to have the most access to any sort of, for example, embolic agent, balloon, stent, wire, catheter, whatever you might need, they'll have it. Whereas a lot of these smaller community private practice-based IR labs, where maybe they don't have those partnerships, maybe they don't have those resources, they might only have glue, right, for their embolic agent. They might only have a bare metal stent compared to a covered one, which, we want that patency for. And so it's really going to be user dependent or department dependent in the sense of what resources are available. But even more microscopic than that, you have different IRs that trained with different technologies, different tools, and they prefer certain ones over the others, right? Some might really like glue as an embolic, whereas others are like, I only coil. And so that's like the differences between them. It's really preference on that end. However, that being said, you should be good with using any of these materials at any point in time. And that's what a lot of IR programs are doing now, is trying to increase the breadth and depth of IR training that you get so that you're comfortable using all of these different tools. The reasoning for that is because I could go into a case planning to use glue, knowing that this is the indication of the gold standard. However, when I get into that vessel, let's say that somehow, some way, the vessel anatomy is all messed up. There's a ton of collaterals, whatever it might be, and glue is no longer the best solution to use, right? High risk of non-target embolization, meaning the glue goes everywhere and I start to embolize things that I don't want to, right? Then you have to be really quick about changing your plan. And so even though things might be gold standard, IR is a really fast-paced changing field where case to case, even though you might go into it with a plan, it's really dependent on what's happening in the moment. You might switch up to using a different wire, different catheter, all the way to, hey, instead of embolizing this, I'm going to walk out of the case. So I think all of those features that you mentioned, the department dependency, the user dependency, and even the case dependencies influence what are you using.
Great presentation, Zach. I had a quick question on the stent types, like the slide on that, specifically on like the TIPS procedure. I know you mentioned it like it was like a specialty stent. Because I looked it up and it was like EPTFE covered stent. I'm not sure if like you like I don't even know what that is to be honest with you. So I was wondering if you had any insight on that, and I guess for patients like because that's like the most preferred stent, like the gold standard over bare metal stents. I'm not sure if you know of like patients that like might have contraindications for that stent where they have to go like IRs have to go elsewhere for like a different type of stent for those like
Yes,
procedure.
I I'm a little bit, I'll be honest, I'm a little bit unfamiliar with the coding name of that. However, what you can really imagine is that in a TIPS case, you're traversing the basic steps of it is you're traversing the hepatic vein and connecting it to the portal vein to decrease that pressure, right? But in order to connect those vessels, you have to go through, usually in a classical TIPS case, through the liver parenchyma. And so that's the all that tissue that you doesn't normally see that high volume of blood, right? And so you can imagine the reason why you put that stent in is to connect those vessels, yes, but to also prevent the too much, I guess, contact where blood should not be going, right? Because that liver parenchyma can't handle it. And so, generally speaking, from my understanding, that coating that you mentioned, what it does is it's kind of acts like a covered stent, for lack of a better word. It's a metal graft that gives that scaffolding structure, and then it's a covering that kind of keeps the blood and the liver parenchyma separate from each other. And so then you have that tissue ingrowth around that covered stent, but then the blood is able to pass through just fine. And so that's kind of the basic understanding. The reason why it's like a specialty stent is because this is what's most commonly used for a TIPS case. But I do imagine that there are other brands and other stent types that you can use. I just listed the most commonly used ones, at least that I've heard on rotations.
I know you briefly talked about back table skills. I'm wondering, from your experience, what are some of the more user-friendly devices and what are some of the more difficult devices to use?
Yeah, surprisingly, the simple back table skills that you can think about, like handling a wire, is a lot harder than it looks. The attendings, they just go really quick with like looping things back and forth, and you're like, I can do this. I don't know what's so hard about IR. IR is easy. But then they give you the wire, and suddenly it's flopping everywhere. You break sterility. They're all pissed off at you. The nurses don't want you to work the table anymore. Believe me, it happens to everyone. I've done it so many times. However, that being said, the ones that are most user friendly are the ones that you're going to kind of have those simple motions. Things like flushing a catheter. It might be hard to screw it on at first, but it's pretty easy to push down that syringe, right? Or even keeping the back table clean. Those little things are things that nurses, techs, the attendings appreciate as well. Just because it can get really messy in IR with tons of tubes lying around everywhere, tons of catheters, tons of wires. And so the simple acts of keeping your table clean, keeping everything flushed all the time, because we're sending things through the vessels. Those have tons of blood that you can imagine catches up inside of them. And so you don't want those thrombi to form. You don't want to be the one because you didn't flush a catheter or flush a sheath to send a thrombus down and cause a PE, right? And so those simple acts are the most user friendly. However, the most useful things you can do is really, like I said, this attending something like this, learning the tools of the trade. Because whenever you're going through any IR procedure, efficiency is key. And that's why attendings are so fast and so good at it, is because they know what tools they need, they know the next steps, and they don't have to think twice about it. And so when you're in the back table and you know all your tools, can anticipate what's the next step that this interventionist is taking. What is the next tool that they'll need? I can have it flushed, prepped, ready to go, so that as soon as we get into that step of the procedure, I can hand it to them, they can start threading it down, and they move on with their life, right? And so those are the most important skills that you develop. Of course, there's easier things and harder things, but the biggest thing is I would say, like, don't be afraid to ask your nurses and techs to work that back table and to try it. Or even to scrub in a little bit early to the case before the patient's in the room and say, hey, can you teach me what are all the things that we need for this case? And what are all the things that are on the table? How do I use them? Is there any sort of order that I should be aware of for that back table? Well, I think that's, oh, Jason, did you have some question or something?
No, I was just gonna ask if anyone else had any other questions.
I had a quick question, if there's a minute.
Sure, go ahead.
Yeah, I was wondering, just like with all the nomenclature, all the types of tools, how long did you feel like it took you to get comfortable with like back tabling, understanding everything? Was it like a rotation in and you felt pretty good, or was it kind of a process?
Oh, definitely not. I've gone through thus far about three IR rotations and then two other informal IR experiences where I spent a significant amount of time. So you can basically account it for being like 4 to 5 IR rotations in, and I'm still learning. The tools of the trade takes a long time to learn, partly because there's so much that's already built and existing. The other part of it's because so much technology and innovation is already being done. So you're going to see tons of new wires, even 2, 3, 4, 5 years from now, tons of new technologies. So really what it is clinical experience and time, and then also some self-study too. You guys just sitting by through this lecture probably are way ahead of anybody who hasn't personally studied the tools of the trade. So when you go in for your first IR rotation, you're like, oh, wait, I remember what a catheter size is. I remember that this is the French. I remember what this function is for the catheter. So doing these little things like this over time and then pairing that with clinical experience will get you that mastery for the tool of the trade. But it's a continuous process. Don't ever feel like, oh, I only did one rotation. I still don't know what I'm doing. I still don't know how to work the back table. I should not do IR. I should not try my hand at the back table ever again. No, that's not the mentality to go with it. If anything, the more time you spend and the more initiative you show forth, the more people are willing to teach you and the more that you will master these tools.
Thank you.
Mhm. Cool. Well, I think that's all the questions we had. Just wanted to say thank you guys so much once again for joining this talk. And I'm hoping we'll be working with the executive team to make some of these slides into like a quick reference study guide or notes so that people are able to kind of utilize these on the go whenever you're on rotations and you don't have to flip through textbooks or lectures or the slides again. But thank you guys so much for attending. And if Jason and Nick and Matt don't have anything else, then I think we're all good to go.